Then you want to be together, might be easier.
Hello, can anyone hear me?
Yes. Okay. Sound good? All right.
You guys can hear me now? Do I sound okay?
Yes, you sound great.
Okay.
And Dr. Singh is also coming in now too. So we have everybody.
Wow.
100% participation.
We get it. Hi, Dr. Singh. Welcome.
Like there's a lot of people on silent right now. They're muted.
Oh, hey everyone.
Greetings, Dr. Singh.
How are you?
Hi,
Okay.
Dr. Singh.
Hi, how are you, Melissa?
Hey, there's Dr. Rosenflit too. Hi.
Greetings.
The gang's all together.
I have 9 a.m.
Me too. We can start then, if that's okay with everybody.
All right, I'm going to let everybody in now.
Yes, please.
Okay.
I'll kick it off.
Let's give them a second to 10 people.
Okay, great.
Sorry about that.
Perfect. We should have everybody in.
Very good. Well, hello, everybody. My name is Sarah Flynn, and welcome to the FCS Foundation's Patient Caregiver Introductory Virtual Meeting. We are delighted to have this opportunity to meet all of you, see all of you, and get to hear from all of you with today's meeting and continuing forward. Next slide, please. My team at Innovative Biopharma helps the FCS Foundation put together meetings such as this. So again, thanks so much. We wanted to cover off on just a couple of housekeeping notes. Some of you may have a lot of Zoom experience, some of you maybe not so much. So just a couple tips and pointers for today's call. We wanted to make sure that you knew right now your lines are muted and your camera are turned off. If you wish to turn your camera on, though, that's absolutely your prerogative. Please feel free to do so. Your microphone, though, we would just ask that you please keep that muted to minimize any background noise that might arise. And also, you can adjust your screen. Hopefully, your slides are the biggest part, and the video participants are either on the top, the side, the bottom. But you can change that around as you'd like by using the view options, minimizing or maximizing your screen. And there's also a gallery view. So please feel free to play around with that and whatever works best for you. As you're doing that, you might notice in the bottom, there's a bar for controls, and in that is a chat box. And we'd encourage you now and throughout today's event to just feel free to chat in any questions that might arise as you hear and listen to the presentations. That chat feature is really helpful. Just pick your recipient and we'll get your message. Also, if you experience any technical issues whatsoever, today's producer is my colleague, Chad Johnson. And Chad's number's on the screen, but just in case someone might not be seeing the screen for some reason, his number's 303-995-0847. 303-995-0847. And my number's there too. I have my mobile phone right here. Anything you need, please just reach out to us. We're happy to help. One point to note is that this meeting is being recorded. For any of the patients or caregivers who may not have had the opportunity to join us, we do have it on record. So just be aware of that. And we are so excited that post-meeting, you'll be receiving from us an email with a print-ready recipe book from Miss Mary Philando, who you'll be hearing from very shortly. So thank you, Mary. And with that, I wanted to turn things over for introductions to Melissa Getz and Lindsay Sutton, who are both co-founders and co-presidents of the FCS Foundation. Melissa?
was muted. Hi, everyone. Good morning, good afternoon, wherever you are. We are so excited that you're here with us as we do this for the first time ever, and we're so excited to connect with everyone. My name is Melissa Getz. I live in Albany, New York, and like Sarah said, I'm the co-founder and co-president of the FCS Foundation. My daughter, Juliana, is a patient with FCS, and she is 7 years old now.
Hi, everyone. Thank you so much for joining. We are ecstatic to have this meeting. So my name is Lindsay Sutton, and I am the co-founder and co-president of the FCS Foundation, and I am also an FCS patient. Next. The FCS Foundation is incredibly proud and very fortunate to have such an amazing medical advisory board. And today we have them on the call with us. In September of 2019, we had our first inpatient meeting with them, and I'm going to allow them to introduce themselves today. We will start with Mary Philando. Mary?
Hi, I'm Mary Philando, a dietitian in Seal Beach, California, and been cooking low fat since the 90s and excited to speak with you today. Thanks.
Thank you, Mary. Dr. Singh?
Good morning, everyone. I'm Vikesh Singh. I am a gastroenterologist specializing in pancreatitis, and I work at Johns Hopkins Medical Institutions in Baltimore, and I'm excited to be on this call today.
Thank you. Dr. Rosenblit?
Muted.
Paul Rosenblit, and I am a endocrinologist, and I have a interest in FCS, and I've had a couple of patients in some trials for volanesorsen, and I'll go on from there.
Great, thank you. And Dr. Ahmad?
Hi, my name is Dr. Zahid Ahmed. I'm a endocrinologist as well, just like Dr. Rosenblit, and I specialize in lipid disorders. We have several lipid clinics here in Dallas at UT Southwestern. And for years and years, the clinics have focused on people with rare genetic lipid disorders. So we have seen quite a few cases of FCS. We probably follow about 15 patients with genetically proven FCS at the current time, and even more who don't have genetically proven, but most likely do have FCS.
Great, thank you. Next. In today's meeting, we will be introducing the foundation and its purpose. We will be providing you with resources and support and answering your questions and concerns. Next. Here's an overview of today's agenda. We will be talking about the FCS Foundation and introducing it. You will hear from Arrowhead, Axia, and Backpack Health, followed by a medical advisory board presentation, an interactive Q&A, and then a look ahead and concluding remarks. Next. Thank you. A little bit about how the foundation got started. Melissa and I co-founded it in 2016, and we actually met at a patient meeting in 2015. At the time of that meeting, I was in my mid-20s, and I had never met another patient living with FCS, and I never thought that I would meet somebody with that disease. So when I got to that meeting and I found Melissa and other patients who felt the same way as I did, that we would never meet anybody, we realized that there was such an unmet need in our patient community, and we wanted to work to bridge that gap. We wanted to connect patients and caregivers with other patients and caregivers, as well as with healthcare providers who specialize in FCS, as well as introducing patients and caregivers to industry members. So about 6 months after the meeting, I called Melissa, I'd only met her once, and asked if she wanted to co-found this foundation with me. And we got to work. We established our board, and in June of 2016, we became a nonprofit, the FCS Foundation. Next slide. We are an organization committed to helping individuals and caregivers affected with FCS. We started patient-focused, and we still continue to be very patient-focused. We want to help patients receive their diagnosis. We want to connect patients with healthcare providers and other patients, and we want to provide resources for our community. There are 3 main platforms that you can stay connected with our foundation, and that is through our website, through our private Facebook group, which also acts as a support group, and our Twitter page as well. Next. Today I will be introducing the FCS Foundation Board of Directors. A little bit about myself. I was diagnosed with LPLD, lipoprotein lipase deficiency, at 5 weeks old. I gained a lot of weight as a baby and I cried a lot, so my parents took me in to the doctor, and with a blood draw, my blood was found to be Pepto-Bismol color pink. My triglycerides were 30,000 at the time, and I was having my first attack of pancreatitis. So I was diagnosed then. I did okay until about age 7. I got another attack of pancreatitis, and from that point on, about every 3 years, I was in the hospital. In high school, I had necrotizing pancreatitis. My triglycerides were over 12,000, and I was in ICU for 2 weeks. Half of my pancreas is completely damaged from that attack. After that attack, pancreatitis seemed to spiral, and I started getting sick a lot more often. And there was a 2-year period where I actually was getting attacks every 8 weeks, almost to the day. Luckily, I seem to have overcome that, but I still suffer with the chronic pain and the chronic fatigue that so many of you on this call I know suffer from as well. I'm very hopeful for treatments, multiple treatments in the near future for our community. So now I'm going to turn it over to Young, and he will introduce himself.
Hey everyone, I hope you can see me well and hear me well. My name is Yang, and I'm a technical guy in the foundation and helping run the website and stuff like that. I am also a patient. My first onset of this pancreatitis is probably when I was really young, less than 100 days in my life. But at that time, the hospital just know I have very high triglycerides in my blood, but they do not know what's going on. And growing up, I remember like there's one day my wife actually bought me a book, how to cook for patients with high triglycerides in their blood, and the first chapters, are listing all the causes. And that was like, I read that, I found out, maybe I'm one of that rare type. So I talked to a lot of doctors about that, and then no one actually really believe it. They just want to run their course of a diagnosis and treatment and everything. Of course, all those things didn't work. But at last, at age of like 35, I finally did a genetic test and confirmed, what I guessed. I have this FCS condition. Right now, to manage that, of course, we all do a low-fat diet, and on top of that, I run every day. As long as I'm not sick, I run every day for at least 10 minutes or 1 mile, but usually end up like 30 minutes and 3 to 5 miles. So that's my story. So I think we're together here to fight this FCS. Yep, that's it.
Thank you so much. And now, Fred, I'm going to have you introduce yourself. You're muted, Fred.
Good morning, everyone. It's nice to be part of this organization. Again, we've been in FCS Foundation for about 3 years now. We got off to a good start, thanks to all the efforts of Melissa and Lindsay. My situation is that my triglycerides started increasing when I was at age 50, and that's when I started seeing Dr. Rosenblatt. And it has not been easy travel to not knowing exactly what the disease was. Felt like I was the only guy on the face of the earth having this disease, and having this FCS organization has been a godsend, feeling like there's somebody else besides me. When I saw the rest of the folks who had the same problem as I did, there was such a connection. I'm a treasurer, as my title states, and I was on the trial with the Way Libra, and My caretaker is Lynn Sereni, who's got her own computer. I should probably ask her to join me so the rest of the folks who are new could put us together. I'd rather be remembered by her than with my own face, so it's a lot easier. I'll cut that short. Good to see everyone. God bless, and wish you all well.
Thank you, Fred. Darlene, if you wouldn't mind introducing yourself.
Hi, everyone. I'm Darlene Vall, and I'm the secretary for the FCS board. My story is very much like Lindsay's. I was very sick as a baby, and I said I was diagnosed around 4 weeks old. It may have even been sooner. I just didn't do very well as an infant. My mom brought me into the doctors, and very similar, I was actually having a pancreatitis attack as an infant with my triglycerides over 30,000. So Lindsay and I are very similar. After that, I was good until about 8 years old. So again, very similar to Lindsay. I didn't have as many issues as a teenager. I was very active, and I was in a lot of sports. So I think that helped me because I did exercise a lot, and I think that helped bring my triglycerides down. As an adult, I've dealt with, during pregnancies, it's been an issue. And I know a lot of us have spoke about that on the Facebook site. I'm sure we'll get there, but I'm so happy to be here and be a part of the foundation, and I look forward to what comes next.
Thank you so much. And Melissa?
Hi, everyone. Like I mentioned earlier, my daughter Juliana was diagnosed with FCS. She was 7 weeks old. We went into the hospital. She had triglycerides about 24,000, that Pepto-Bismol color blood that Lindsay talked about, and pancreatitis and a kidney infection and a liver infection. So thankfully we were able, our physicians there knew what it was pretty quickly, although struggled to figure out, how best to treat it at that time. So, we just follow a really low-fat diet. She's doing well. She's 7 now. But certainly hearing Lindsay and Darlene tell their story, it's hard not to feel like another round of pancreatitis is around the corner for us. So we just focus on, keeping her active and staying on that low-fat diet, which can be tricky as she likes to push boundaries now that she's 7. And that's it. But what we're just so happy to be here with all of you and hear everyone's story and share some information. Thank you. Next slide. So I'm going to just talk a little bit about the foundation's purpose and responsibilities, what we're doing and what our focus is on. We really are looking at 3 main areas right now. We're looking at education to be a resource and for community. Education, we've attended National Lipid Association conferences, we've attended endo conferences, just to let people know about FCS and to get the word out. We say it's 1 in a million. We think it's probably a little bit higher than that in terms of how often it occurs. We think it goes underdiagnosed. So really just trying to educate physicians and nurses and people who might see this elevated triglyceride show up in their offices or pancreatitis on what FCS is. We've been working on lobbying on Capitol Hill to talk about rare drug approval reform, basically. After some experiences that we've had, we felt like the FDA could do a better job at looking at rare disease drugs and the rare disease patient community and taking our input into consideration. So, I think some of you have helped us with that effort, writing to your congressmen and being part of that process. And I have to tell you, it really makes a difference. The bill is really close to being introduced, which is very exciting for us. And we will keep you all updated on that. And, call for help again, because we have to use our voices to let people know our experience so that change can happen. And we'll be keeping you updated on that. But that's something we're very excited about. And then creating educational materials, updating brochures that are geared towards physicians, that are geared towards newly diagnosed patients, caregivers, really just anything that we can use to help support our community are things that we're creating. The next is for us to be a resource to patients and community with opportunities like this to get us all together, to connect. You know, we're spread out all over the country, and I know it's hard for us, you know, to meet in person and to see each other, but anything that we can do to help answer questions through social media, through email, opportunities like this is important to us. Provide answers to medical questions you might have. That's where our medical advisory board comes in, and we're so lucky to have professionals from so many different areas who can answer questions on certain specifics you may have, and then connect you, the patients, with physicians and with industry partners who are interested in FCS. And mostly to build community. I mean, and that's where this all stemmed from when Lindsay and I first met in 2015. Just that one small meeting with 6 people around the table was life-changing, and making that connection, you know, grew into this, and it still is life-changing. I have to be honest, as Lindsay was telling the story, I was still tearing up because it makes such a big difference. You know, Juliana, you know, my daughter, will never know what it's like to live with this disease alone, because she sees what we're doing. You know, she has conversations with Lindsay. She knows that, you know, I know other people and other kids who have the disease, and just, I think, knowing that for her makes such a big deal. We do want to grow our board, and we have volunteer opportunities for that. If anyone here on this call is looking to help out really in any way, we are here and open to that, and we want to hear from you. And it can be as a board position, it can be just as a volunteer if there's a program that you want to do. I talk with my hands a lot, which is very hard to do when you're on a screen. I feel like I don't know what to say. Any way that you want to work with us, if you have a program idea, or you want to do a fundraiser, or whatever it is, I mean, we're open to that. We're 4 years young, and we are looking to grow in all kinds of ways. So please let us know, you know, how we can work with you and work together on any programming or anything you want to do to help us out. And then we're also, you know, providing connection through social media and through Backpack Health, who will talk to you a little bit about what they're doing with us later on. Next slide. So looking ahead, our 2-year plan is to have a family meeting, which we were looking to do this past spring, and then, you know, life has other plans. So we adjusted, and we're here like this instead. But our goal is in the next year or so to have that meeting in person so that we can all connect face to face. Looking to update content, again, you know, with the materials that we're giving to patients and physicians, looking to update our social media content and have blogs. You know, that's an opportunity that if someone wants to write for us, an experience that they've had, or a story, or anything for our website, we really appreciate that. So updating all of that new content and recipes. And then making connections, you know, just having you all connect with one another, and be able to grow and feel supported in this community. Next slide. So we have 3 guests here with us today who we are so excited are here to share with you about what's been going on and what they're working on, and how we're working together with them as the foundation. We have Dr. James Hamilton, who is from Arrowhead Pharmaceuticals. We have Lori Gorski from Axia Therapeutics, and Lauren May from Backpack Health. So each of them are going to share a little bit about what they're working on and how they're impacted by the FCS community. So I'll hand it over to Dr. Hamilton next.
Yeah, thank you, Melissa. Just confirming everybody can hear me okay. Thanks for the foundation for the invitation to speak. And I'll just provide a brief overview of Arrowhead and what we're working on. If we can go to the next slide. So everything Arrowhead works on is focused on RNAi, or RNA interference. And one of these programs targets ApoC3 as a treatment for hypertriglyceridemia. You can go to the next slide. And as you can see in our pipeline diagram here, that Arrow ApoC3 is one of our key programs. We have 8 clinical programs ongoing, but I call Arrow ApoC3 one of our lead programs. And again, these are all RNA interference drugs. Next slide. And so what is RNAi or RNA interference? This is a way essentially to turn off or to silence any gene, the expression of any gene. Normally, genes, which are our DNA in our cells, genes are transcribed into RNA, specifically messenger RNA, which is then translated into proteins. And what RNAi does is basically intercepts this message and targets for silencing the messenger RNA that is transcribed from the genes. And it does this in a manner that is sequence specific or gene specific. So you're only silencing the message from that single gene, which is important because you don't want to silence messages from other genes that may have important functions. It's key to emphasize that this is not a gene therapy. This is not gene editing. And so those modalities can actually permanently modify the genome. The effect of RNAi is transient, although it's durable, and a single dose, as you'll see in a couple slides, can last for a few months. The effect is transient and it wears off over time, and at that point you can give another dose. Next slide. Specific to this program, ARO-APOC3, again targeting the expression of the APOC3 gene. Most of our programs are targeted at liver expression of proteins. We're very good at silencing genes expressed in the liver, and it so happens that APOC3 is primarily expressed by the hepatocytes in the liver. And so this technology is very good at reducing levels of APOC3. And so why does that matter to patients with FCS? Well, APOC3 is essentially an inhibitor of triglyceride metabolism. So it blocks clearance of triglyceride-rich lipoproteins, and it slows metabolism of triglycerides in the peripheral capillaries. And so by silencing APOC3, we are inhibiting the inhibitor. And by doing this, enhancing peripheral and liver-mediated clearance of triglycerides. And so this acts through lipoprotein lipase dependent and independent mechanism. The end result is a reduction in triglyceride levels. And we can go to the next slide. This is just some very top-line data that was presented at AHA last year in healthy volunteers. These healthy volunteers had to have modestly elevated triglycerides. So most of them were in the 200 to 300 range fasting baseline triglycerides. It was a dose escalation study, so all the various colors here represent different doses. And I think the key message here, after a single dose on day 0, you can see the bottom 2 lines. This is the 50 and 100 milligram single dose yielded reductions in triglycerides of about 60 to 70% or so in subjects with modestly elevated baseline triglycerides. And what's notable is the duration of effect, that a single dose really can last out through 12 to 16 weeks. You start to see maybe a little bit of an uptick around week 12. And so our expectation is that this drug would be administered quarterly, approximately every 3 months as a subcutaneous injection. At the very bottom, we recently described some data from a cohort in this same study where we evaluated patients with chylomicronemia. And so these were not specifically FCS patients. Most of these patients were multifactorial, so they could have had fasting triglycerides greater than 880 mg per deciliter from any cause. Many of them were heterozygotes for lipoprotein lipase deficiency. Their baseline triglycerides were over 4,000, and we saw, again, this was after 2 doses, one on day 1 and then day 29, about a mean maximal reduction in triglycerides of around 95%.
Wow.
And so this data the rest of this data is embargoed. We'll be presenting this in its totality at a medical conference later this year. Next slide. And just some summary safety data. This is from the healthy volunteer component of the study. There were, again, presented earlier at AHA, this was AHA of 2019, no serious adverse events, no severe adverse events. We see the occasional mild injection site AE that's usually some erythema, little redness or bruising at the injection site that tends to be self-limited, goes away within about 48 hours. And the occasional mild transient ALT elevation also typically returning back to baseline by end of the study. And no other associated adverse events from lab abnormalities, no evidence of thrombocytopenia to date in the study or with this drug. Next slide. So in conclusion, we think ARO-APOC3 as an RNAi drug shows potential to not only to lower APOC3, but to lower triglycerides. So far has a favorable safety and tolerability profile and has demonstrated significant and durable reductions in triglycerides after a single dose. The preliminary data in patients with chylomicronemia also shows what we'd expect, the significant reductions in triglycerides. And we think that given the durability that we're seeing, that we could dose quarterly, maybe every 4 months. I think quarterly probably makes the most sense. Our goal is to complete the current study that is started in healthy volunteers and now is in patients with elevated triglycerides and with chylomicronemia, with the plan of launching a study in patients with severe hypertriglyceridemia, including FCS patients, likely later this year or early next year. And so I think that's my last slide. I'll go ahead and turn the floor over to Dr. Laura Gorski from Axia, and happy to field any questions at any time.
Thank you, Dr. Hamilton. Can everyone hear me okay?
Mm-hmm.
Wonderful. So I am not a doctor, but I am very, very grateful to be joining you here today. And I think this is such a marvelous moment for the FCS Foundation and for the community to have a meeting like this. And it's been wonderful to be part of this journey with you all. So I'm here to tell you a little bit about Axia, a little bit about our programs and how we're engaged with the FCS community. So on this slide, Axia was founded in 2015. The word Axia is derived from a Greek word that means precious and rare. And when the company was founded, our CEO was the first employee, and her first hire was somebody to head up patient advocacy and to build a community, because we knew that our success and our growth as a company would not happen without the involvement and collaboration with the FCS community. I began working with Axia and the FCS Foundation in 2017, and there have certainly been peaks and valleys along the way, but it's been such a wonderful journey, and I think we've learned a lot from each other along the way. I wanted to talk a little bit about how we are working together. The first is with the clinical programs that we have. Some of you may be familiar with our APPROACH study. So APPROACH was the largest clinical trial ever conducted in FCS, and that served as a foundation for our application for approval for a drug called Waylivra. And I'll talk a little bit about that, where we stand in one moment. Community engagement, I think that it's been very much a collaborative exchange of information, and we would not understand this disease the way we do without the subject matter experts that are on this call here today. I mean, you are the experts in living with this disease, and it's been a privilege to get to know your community the way we have. And beyond a therapy, it's been very beneficial for us to understand what other needs your community has. So how else, besides an approved product, can we help support you in your day-to-day journeys with FCS? And global commercialization as well. So FCS, or Waylivra, is approved in Europe, and we are increasing access to that to patients who need it. But along our journey in Europe, we're learning more about Waylivra, we're learning more about this patient community, and we will apply those learnings to our work here in the United States. Next slide. So in addition to some of our traditional advocacy activities, including the focus groups, we are committed to ongoing innovation. So with Waylivra, you may all know that back in 2018, we received what was called a complete response letter from FDA. So at that time, Waylivra was not approved for commercial use in the United States. And it was a sad day for Axia, but it was a worse day for the patient community. And since then, we've been working with FDA and doing our best to find a path forward toward approval. And if you have not heard, I wanted to let you know that we have not given up our fight for FCS and for Waylivra, and we do intend to resubmit that application for approval this year. And so that work continues. The other program I wanted to mention is one called ApoC3 LICA. And we announced back in January top-line results from a study of ApoC3 LICA in patients with cardiovascular disease and hypotriglyceridemia. Based on this top-line data, we intend to move forward with a study specifically in FCS, and you're going to be hearing more about that in the months to come. I do want to emphasize, though, as excited as we are about ApoC3 LICA and the promise that that potential therapy has, our focus remains on Waylivra as the most advanced program to support patients in the United States. Next slide. So what have we learned? We've come a long way together, and I think Lindsay and Melissa and Fred, you've already shared stories about the power of communication and the power of connectivity. And so until you have a therapy to really address all of your needs, that connection with one another makes such a difference. And back in 2018, we actually published some survey data about the value of FCS community connecting with one another and the positive effect that being part of a community has on your quality of life. And so I am so happy that each and every one of you is on this phone call today. We've also learned that there are a lot of very practical needs that this community has. And so we do have resources available to you if you don't have them already about, for example, how to talk to your physician about FCS. If you're in an emergency room, how do you talk to an emergency physician about your journey with FCS so you're not accused of looking and being a drug seeker, for example. Foods and nutritional elements to help you manage your disease. And we still get questions all the time about MCT oil and how am I supposed to use that. So we do have these resources available to you. The next slide, please. And that's through a channel called FCSFocus.com. And so if you are not already subscribed to this, I really do encourage you to take a look at this. This is the channel where you will find the most updated information from Axia on where we stand with our programs. You'll find access to a lot of the tools that we do have available to help you to manage your disease and to talk to others about FCS. And we're doing our best to stay very current. And so the past couple of weeks and months, I've had a lot of conversations with patients who are living with FCS, but now we're in the time of COVID too, right? And it's not lost on any of us that it's a challenging time in the world, but it's especially challenging if you have a rare disease. And we have heard stories about inability to access lean proteins and things like chicken in a supermarket. Or if I have an attack of pancreatitis, is this the right time for me to be going to an emergency room? Will I be taken seriously? Am I putting myself more at risk? And so I know that there are needs that are heightened right now for the FCS community. And through FCSFocus.com, we're going to be providing more education, tools, and resources. For example, how telemedicine works and how you can use telemedicine to help talk to your doctor about your symptoms. If there is another pandemic, how can you prepare now to make sure that you're safe and healthy and can endure another situation like what we're enduring right now? And we're also going to have some fun tools available as well. So excuse me, the global community is all going through this moment with COVID right now. So we're going to be launching a global recipe challenge. Somebody just called me Tina Fey. Sorry about that. Caught me off guard. We're going to be announcing a global recipe challenge where we're going to be soliciting your recipe ideas and compiling them over the next 2 months. And we're going to be doing that with your other fellow FCS patients around the world. We're going to take these recipe ideas, we're going to run them by a nutritionist. So we may be calling on you for some help, Mary. And we're going to compile a cookbook that we can make available to you. So I would love to have your recipe submissions, but if you are not so inclined, certainly sign up for fcsfocus.com and we'll make sure that you have a copy of that recipe book once it's available. Next slide. So this is my last one, and I am so grateful to be a part of this meeting today and to have been along this journey with you. Being part of this call today and being connected to the FCS Foundation is a wonderful way to stay sane and to stay healthy during these weird times. And I commend Lindsay and Fred and Melissa, all of you, for how far you've come as an organization. And if there's anything that AXIA can do, any ways that we can support you, I'm happy to share my contact information after this meeting. And I look forward tremendously to continuing our work together. And that's it. I think I'm supposed to turn the call over to to Lauren.
Thank you, Lori. Hi, everyone. My name is Lauren May, and I'm the Senior Director of Compliance and Subscriber Services at Backpack Health. It's one of the longest titles at the company, so excuse me for tripping over it a little. It's such a pleasure to be here with the FCS community today. Thank you so much for having me, as well as my colleague, Rob Goldman. So a little while ago, the FCS Foundation decided to team up with Backpack to bring a customized health management experience to the FCS community. And the foundation has been doing a lot of work behind the scenes to bring the tool to you soon. So I just have a few minutes today to tell you what Backpack is, why it's of interest to the FCS Foundation, but there will be a lot more info available to you from the foundation in the near future, so stay tuned on that one. Next slide, please. Oh, wait, no, we're here. So what exactly is Backpack Health? At a very high level, Backpack is an app you can use on your Android or Apple device, as well as on the web, and it allows you to securely store, manage, and share all of your health info, all of your family's health info, all in the same spot. If you're caring for someone, like a child or an elderly parent, you can create a profile for them, and you can manage their health info in the same place that you manage your health info. So there's no logging out of one system and logging into another with new credentials. It's all in the same spot. Melissa, I'm also a hand talker, so Zoom really limits me. It doesn't matter what conditions you or your loved ones have, Backpack can be used for absolutely everyone. In the Backpack app, we have something called share cards, and the most important one is something we call an emergency share card. So you can put the most critical details about your health, including your emergency contacts, on your emergency share card. And then every emergency share card has a unique URL you can add to a medical bracelet, to the lock screen on your smartphone, or any other place where emergency responders might check to get more info about you and your health condition. So that's something we hear from our users that they absolutely love that feature. You can also create your own share cards, and you can include only the health info that you want for a given audience. So you can then go and share that info with a school nurse, with a babysitter, a professional caregiver, a travel buddy, anyone else that makes sense. And you can change the info that's on those share cards and who has access to them at any time. So as a Backpack Health user, it's really important to us that you are in total control of your own information. And then finally, Backpack is multilingual. So we are really, really proud to be available in 6 languages: English, Spanish, French, German, Italian, and Portuguese. So you can use the app in your native language if it's one of those, or you can easily translate your health info if you're traveling abroad. Next slide, please. Thank you. So what does it mean that the FCS Foundation and Backpack are working together? So the FCS Foundation is in the process of creating an FCS specific group on Backpack, and that group is going to provide a customized experience for the FCS patients and caregivers, and also make important resources available within Backpack Health that the FCS community can access at any time. Individuals who join the group can share the information they choose with the FCS Foundation and help answer important research questions about FCS that the foundation identifies that they want to work toward. And as with everything that happens in Backpack, sharing with the group is done in a way that doesn't directly identify anyone. So the FCS Foundation and Melissa and Lindsay will soon have much more to share about the Backpack Health group. And speaking for the Backpack team, we are really looking forward to working with all of you. I'll turn things back over to Lindsay now. Thank you.
Hi, thank you so much for sharing all of that with us. Like Sarah mentioned in the beginning, if anyone has any questions about anything that they've heard, feel free to use the chat feature, and we'll be able to swing back around and address those questions. But, if it's a lot to take in also right now, so if questions come to you later on, there is no expiration on that. So just, feel free to email us any of the questions that you come up with, and we'll make sure we bring in the right people to answer them. As Lauren mentioned, Lindsay and I are working right now on kind of curating the content for Backpack Health. So as we get more, as we sit down more with that and make sure that we tailor it to FCS specific needs, which is one of the reasons that we had that initial questionnaire when you registered, is just to capture as much as we can about how you all are impacted by FCS. It is so different for everyone. There is no one size fits all. So the more that we can understand about your unique experiences, the better we can tailor Backpack Health, the better we can tailor our information to physicians, the more that we can just kind of figure out what everyone's struggling with. So thank you for filling that questionnaire out. All of that is de-identified and just really is going to help Lindsay and I kind of figure out what we need to do moving forward and what are the real issues that everyone's experiencing. Next slide. Next, we're going to have just a general discussion about FCS, where we use some of the questions that you all had listed in that initial questionnaire, the questions that you had for the Medical Advisory Board. So we're going to go through those. Dr. Ahmed is going to moderate that discussion. Other members of the Medical Advisory Board, please feel free to chime in if you have expertise or some experience in that area. And if there are other questions, again, just please continue to keep them coming through the chat feature so that we can address them.
Yeah, thank you very much, Melissa, and I'm really happy to be part of this. We can go to the next slide. So as you all know, FCS is a condition where people have extremely high triglycerides, and it's almost always because of a clearance problem, but you're not able to remove the triglycerides from circulation. And there are several consequences of that, and many of the people on the call have probably experienced much of these, or if not all of these. The most serious thing that us providers worry about, of course, is recurrent acute pancreatitis. And this is pretty variable. Some people with FCS never get it in their entire lives, and others get it once a month. And I believe one of the questions people had asked is about that, and we can go into a little bit of detail of why that might be. Other people don't get pancreatitis, they get abdominal pain. And maybe, there's a thought that those actually may be mini pancreatitis attacks. And of course, if you keep getting pancreatitis, you can get pancreatic failure, which can then lead to diabetes or other metabolic complications. There can be hematologic manifestations like hemolysis or platelet count issues. Thrombocytosis and thrombocytopenia are both actually opposite conditions, but they involve changes in your platelets. And we all need platelets to kind of clot every time we make a cut, either inside or outside our body. We need the platelets to kind of clot. Many patients with FCS have reported neurological symptoms, some cognitive impairment. Sometimes people describe it as being foggy. Some people describe memory loss, fatigue, or peripheral neuropathy, which is loss of sensation or funny sensations in the fingers and hands. And of course, there's a tremendous emotional burden to having FCS, especially if you're having pancreatitis, but even if you're not, there is a lot of anxiety and depression. There are feelings of guilt, and sometimes us healthcare providers make that worse. We accuse people of being alcoholics or other things, or take out gallbladders when we don't need to. But really, there's nothing to feel guilty about. This is an FCS patient has this. This is who you are, and it's not it shouldn't be a source of guilt. But I understand that it is. And of course, there are social constraints. If you can't eat fat, it makes it very difficult to eat out. Makes it very difficult to eat prepared meals, and all of this leads to a decreased quality of life. And there are dietary restrictions, unfortunately, that you can only take 10 to 20 grams of total fat in a day. Or at least we know that doing that seems to reduce the triglycerides and reduce the chance of pancreatitis. And Mary, after I talk, Mary will talk, and she has some excellent slides on what that diet may look like. And then there's a financial burden to all this, and that is a really big deal, not just to patients, but to society, that you miss work, that ER, ICU visits. Sometimes there are very lengthy hospitalizations and difficulties with employment. So all these things have to be taken into account when we talk about FCS, and I'm sure, more than sure, that many people on this call have experienced some, if not all of these. I forgot to mention that at the very bottom of the screen, you can see some of the clinical manifestations. And so many of you have probably experienced this too, where you get the skin rash referred to as eruptive xanthomas. It's literally triglycerides erupting in the skin. They have to go somewhere, so sometimes it goes to the skin. Lipemia retinalis is the way that blood vessels look in the back of the eye. It refers to kind of a milkiness of the blood. So one of the few places in the human body you can look at blood flowing is the eye, because we have blood vessels in the back of the eye. And so we can see if someone is lipemic, if their triglycerides are very, very high. It's not a perfect technique or a perfect sign, but it is something that we sometimes use. Hepatosplenomegaly refers to the spleen and the liver being enlarged. And that is a result of triglycerides just depositing in them for the most part, especially the liver. And that causes fatty liver. So triglycerides are fat essentially, and they deposit in the liver and create fatty liver. And you can get other GI disturbances. Let me go to the next slide. And so these are some of the questions for discussion that were submitted to us actually. So the first question is there proven medications or alternatives to help lower triglyceride levels, like fibrates, Zetia, fish oil, MCT oil? That is a very good question, and a question that is very key and core to having FCS. Because of the defect in FCS, that it's a clearance issue, mutations in lipoprotein lipase or associated coproteins or cofactors, etc. Because of that, there are very few, if any, medications that actually help. Fibrates and fish oil lower triglycerides in most people, but that's through actions in the liver by reducing how much triglycerides are made. And again, in FCS, it's not a problem of making triglycerides, it's a problem of clearing triglycerides. So those drugs, they can work, but usually don't work too well. Now, I will say that there's a tremendous amount of variability in human beings. One person to the next who may have the exact same genetic condition may be completely different. And so there are people who do respond to some of these drugs, and then there are, unfortunately, most of FCS patients don't really respond. Zetia is a drug that lowers cholesterol, so it doesn't do much for triglyceride levels. MCT oil is something that is a good dietary supplement, a good source of fat and calories for someone with FCS, because it is not transported, it is a fat that's not transported in blood the same way as triglycerides. And so it can be a source of fat in the diet without causing triglycerides to go up. We can go to the next question. So this is something that I mentioned on the previous slide. Why does it seem the symptoms of this disease vary widely from person to person? It is all but completely debilitating for me, yet I read other people have minimal side effects. And that is unfortunately how it is. And this is not just FCS. Any condition is like that. Just about any genetic condition is like that. I deal with another condition called familial hypercholesterolemia a lot, where two people can have the exact same mutation. One will have extremely high LDL and have heart attacks in their teenage years. The other will live until 70 or 80 without any problems at all. Why does that happen? Well, it's rather complicated interaction between environment and genetics. So let's say you do have a mutation for FCS. You could have another mutation in a gene that has to do with pancreatic function. And because of that mutation, you're less likely or more likely to get pancreatitis. And so, those kind of interactions happen. And of course, environment plays a large role too. If the diet can make a difference. So some people get more pancreatitis or more abdominal pain because they have a very difficult time with a low-fat diet, which I don't blame them. It is very difficult to maintain long-term. Not impossible, but difficult. Whereas others, especially people who are diagnosed at a young age, they can perhaps adhere a little bit more. Again, I'm generalizing, but many people who are diagnosed at a young age get used to a low-fat diet and are able to maintain that a little bit more than people diagnosed later in life. That's my anecdotal experience. But I think the main thing, and Dr. Singh, one of the other physicians on the board here, he also talks a lot about, he believes there are genes that are definitely influencing the risk of pancreatitis in people with FCS. We can go to the next slide. Can a person with familial chylomicronemia safely induce ketosis in order to reverse obesity and comorbidity? So I presume from this question that inducing ketosis is via the keto diet, which is quite a fad right now. I can't tell you how many of my friends are on the keto diet, and I am not as big of a fan of it as they are, but they do lose weight. Now, the keto diet involves eating a tremendous amount of fat, and fat are triglycerides, or is converted to triglycerides in the body. And for someone with FCS, I highly recommend they do not follow a keto diet. I have had several patients I know with FCS who here and there have been on keto diet. They got bad advice from healthcare providers and ended up in the hospital with pancreatitis. Now, I don't know if that's the case for every single FCS patient. Again, there's a lot of variability in how we respond to diet. So there may be FCS patients who can do a keto diet and maybe just stick with the healthier poly and monosaturated fats, and they may do okay. But I personally would recommend that a patient with FCS avoid the keto diet. If you're looking for some diet to do rather beyond just the usual caloric restriction and the low-fat diet, one good thing might be the intermittent fasting diet. And just my own opinion, but it seems like if you are able to fast, that might give your body a little bit of a chance to catch up with the triglycerides, and it may help with lowering them. Of course, you have to be careful with intermittent fasting. During the periods when you can eat, you can't overeat during those times. But if you can follow intermittent fasting, you can, maybe that would help. Mary, if you're on the line, maybe you could help answer this question too.
Yeah, hi, Dr. Ahmad. I was just thinking, I also have a lot of friends on keto, but they've been on many things in the past, and I've never seen any long-term results from anything. People always talk about when they're losing weight, you hear about it, and then when they're gaining it back, nobody speaks about it. So it sounds like everyone is so successful in these weight loss efforts. But if you in the keto diet, imagine eating 150 grams of fat per day. That's a lot. You guys, our FCS people are on 10 to 20 grams for the day. So I would say that, there have been no studies with FCS and keto diets. And again, I concur with you, avoid it. I haven't seen much on the intermittent fasting except for diabetes and for weight management, but I know as part of our eating style, we recommend that people balance their food throughout the day because of the amount of production of, triglycerides after a big meal. So if people are intermittent fasting, I wonder if they can really manage smaller portions when it is their time to eat again. I question that. But we'll see more in the future, I'm sure, because intermittent fasting is popular with the other, diabetes and weight management.
Yeah, it's a very good point about, avoiding binge eating if you do intermittent fasting and the periods when you can eat, you really do have to avoid the binge eating. Good, thank you, Mary. And we'll hear more from you in a few minutes. Maybe next question. Are people with chylomicronemia predisposed to atherosclerosis? If so, are blood thinners effective in helping the body deal with an overabundance of chylomicrons? So just so everybody's on the same page, atherosclerosis refers to buildup of plaque in the coronary arteries, which are the arteries that supply the heart, or it also applies to the arteries that supply the brain, or sometimes it refers to the arteries, the big artery that goes down the entire body, the aorta. Now, this is very interesting. People with triglycerides that are slightly high, like the 300 to 500 range, they are known to be predisposed to atherosclerosis. But people with very, very high triglycerides, like above 1,000, like FCS patients, it actually doesn't seem like they are predisposed to atherosclerosis. Not that they're protected. Certainly they can't, smoke and do other things and avoid atherosclerosis. But it doesn't seem like having triglycerides in that range causes a problem. And that may be because it's cholesterol itself that deposits in those arteries, not triglycerides, right? Atherosclerosis is mostly caused by cholesterol. Now, FCS patients will have high cholesterol too, but that's more of a consequence of having the high triglycerides. They're kind of carried in the same particles, and if you can't clear those particles, you're not really clearing the cholesterol. That may be the reason why atherosclerosis doesn't happen as much in FCS patients. But we do run into FCS patients, though, who may have a family history of heart disease, or maybe smokers, or have other bad habits like or conditions like high blood pressure or diabetes. People with diabetes and high blood pressure or smoking are predisposed to atherosclerosis. So, it just depends on what the other things going on with the FCS patient may be. And whether or not blood thinners are effective with chylomicrons, for the most part, I would say no. There may be some exceptions, like heparin is a blood thinner and it activates the enzyme lipoprotein lipase. But we have tried studies of that at where I work at UT Southwestern. It doesn't do a great job of lowering triglycerides. And in addition to that, it raises your risk of bleeding pretty dramatically. And so if you have FCS, I usually tell people to kind of avoid any serious blood thinners. Maybe baby aspirin would be okay, but any serious blood thinners or prescription blood thinners probably should be avoided as much as possible, because when people have pancreatitis, it can convert into hemorrhagic pancreatitis, which means bleeding. So the pancreas can bleed. And that's something you really want to avoid. That would be catastrophic for someone. So that's kind of my quick answer to that one. We go to the next question. When you go to the emergency room or to a new physician that doesn't necessarily understand FCS, what is the best way to speak to the doctor? Right, so this is a great question. And every physician, every healthcare provider is a little different. Some of us have bigger egos, some have smaller egos. Some are willing to listen, some are not. Some are at the end of their shift, some are at the beginning of their shift. There's a tremendous amount of variability. Just like when I went to get a haircut yesterday, I didn't know what mood my barber would be in, whether she would be happy or not, or whatnot. And because she wasn't that busy, she was a little bit happier and was willing to listen to me and take off as much hair as I needed, because I really needed a haircut. This was all done safely with baths and everything, by the way. But it's similar to when you go to the emergency room. You don't really know what you're getting into. The one best thing you can do is be aware of your own condition. So understand what it's called. Know that it's FCS, or familial chylomicronemia syndrome. Understand that it's genetic, and be able to tell the physician or whoever takes your medical history. Sometimes it's a nurse that actually takes your medical history, or sometimes it's just a clerk who says, fill out this form with your medical history on it. It's very, very important that you write in there, I have a genetic condition called familial chylomicronemia syndrome. And if you can, speak to pancreatitis, and the risk of pancreatitis is about, whatever it is, 100 times higher in people with FCS. And then most physicians are pretty reasonable. They're willing to listen to that, and they actually like it when somebody, not like it, but some of them may be okay with it if the patient gives you the diagnosis. So it's not necessarily a bad thing. But the most important thing is to be aware of what you have, to be able to communicate that effectively. And I think Melissa and Lindsay have been working on cards, and you guys heard about the backpack thing that may help. Melissa, Lindsay, do you guys want to chime in this question at all?
Yes. So, like you were saying, I think it's very important to always go into the emergency room or the doctor's being prepared and knowing your condition very well so you can explain it. But the foundation does have a card, and we're working on updating that card with information on FCS, just basically saying this is a real condition and here's where you can get more information, and you know, the key points of FCS and that it can cause pancreatitis, so that you can bring it to the ER or a new doctor, and hopefully that'll help them sort of realize that, you know, this is a real disease and you're not just in here trying to get medication, as so many of us have experienced in the past. So stay tuned. If you don't have the old one, we are working on updating a new one. So we'll get that out to you as soon as we have.
Yeah, just let us know, and we can throw some of those in the mail for you.
Yeah, that's great. That's great to have resources like that. I think that's one of the key benefits of having, you know, an FCS Foundation. Okay, we can go to the next slide. Oh, next question, sorry. How do we seek pain management for daily pain when doctors don't understand why you are in constant pain? Well, that is a very good question. And, you know, again, to make sure your doctor understands why you may be in constant pain, it's very important to understand your own condition and to be able to communicate that. With regards to pain management, you know, that is, it's a difficult time right now. We are going through a lot of media coverage of the opioid crisis and a lot of increased regulation on narcotics and other pain medications. And so many physicians are only allowed to prescribe a certain amount or are under pressure to cut down how much narcotics they are prescribing. But I think there are ways to get around that. It's very important to have a good relationship with your provider. You know, always be professional when you talk about pain management. Always be very clear about what pain you're having and why you may need it. Always be clear about your underlying condition and what the issue is. What you don't want is, and I'm just giving out tips, what you don't want is the provider to have any sense that you may be drug seeking. And I know the people on this call are not drug seeking. Unfortunately, there are people who take advantage of the medical system to do that. And so you want the doctor to trust you, and you want to trust the doctor. If you can, it's a good idea to see a dedicated pain management physician. You know, those clinics exist, and those physicians are really quite well aware of what the different causes of pain and whatnot. So Lindsay or Melissa, did you want to chime in here? I know many FCS patients have gone through this, have had difficulty with communicating about pain management or getting appropriate pain management medications.
Mike, oh, sorry. You can go.
No, I thought I would add a little something to that, because that's something I spend a lot of time in, especially if we presume that the pain is being driven by the pancreas. I remember that once you've had many episodes of acute pancreatitis over some period of time, you are at risk of developing chronic pancreatitis. And one of the problems with chronic pancreatitis or any other disorder that results in visceral pain is that over time that pain may no longer be in the organ, but actually it shifts into the central nervous system. That's what we call central sensitization. And I know that these are all big words, but pain is very complex. And I think most physicians treat it as kind of a singular entity. But you know, the pathophysiology of pain and whether it's still in the organ or it's shifted into the central nervous system, I think is complicated, and probably we could spend an entire, you know, virtual summit on just this topic. But I'd like everyone to really think long and hard about, you know, using opioids to treat this kind of visceral pain disorder, because it's really not the best way to treat it. Over time, the risk of dependence and the risk of actually developing opioid-related complications are extremely high in anybody with a chronic visceral pain disorder. So in fact, you know, my group and others around the country that are getting, you know, a little bit more deep into the pool of pancreatic pain are trying to think of different ways to treat this pain, including using drugs such as neuromodulators. And what are neuromodulators? They're effectively drugs that treat depression, that treat anxiety, that are non-addictive, but what they do is they act in a very focused way at tackling the actual neurotransmitters that are involved in our perception of pain. So they're really good drugs for treating pancreatic pain, chronic pancreatic pain, and we have really good success with this. But I can tell you outright that if you go to see a chronic pain specialist, you're going to be treated with opioids. It's unfortunately the way our system is set up. You know, there's about 4,000 or 5,000 chronic pain specialists in the United States. They would rather focus on doing procedures to treat pain and not really treating visceral pain. So they like to treat visceral pain using opioids. So I have a real fundamental, continental divide between myself and most chronic pain specialists. And so I usually tell my patients to never go to a chronic pain specialist and try to find somebody who can use neuromodulators to better treat their pain. And I know it's very, very hard to do, but that's something that we need to increase access to. I think not only for the FCS patient population, but also any patients who have really chronic visceral pain disorders.
Yeah, that's great input. Thank you, Dr. Singh, for anyone who doesn't know, Dr. Singh is our pancreas expert. So he probably knows more about the pancreas than I would say 99% of the world, I guess. Okay. Is there another question? Can we move on to the next slide or next question? Okay. So that's all the questions that I had or that were submitted that we wanted to go over just now. If anyone has more questions, you're welcome to send them in, I think, through the chat function. And next is Mary Philando, who I got a sneak peek at her slides, and this is a great kind of, pearls. And there's great pearls and tips on how to follow an extremely low-fat diet, which unfortunately to this day is the best treatment we have for FCS.
Hi, and good to be here. Thanks, Dr. Ahmad. I wanted to give you a little bit of background that I did work in cardiac rehab at Cedars-Sinai Medical Center for over 20 years and did a teaching program for cooking classes for 10 years for the Dean Ornish Preventing Heart Disease and Reversing Heart Disease program. So that gave me lots of good experience at eating less than 10% of your calories from fat. From there, I went to work with homozygous familial hypercholesterolemia, another rare disorder, and with the program they were on, they were eating 20% of their calories from fat. So they got a little bit more, but not a lot. And then moved on to working sometimes with the FCS Foundation and also with AXIA, doing some of the low-fat chats and things that we've done in the past that were a lot of fun. So I do refer you to fcsfocus.com because they do have a lot of great resources for you. Like some of the other speakers, I not only speak with my hands, but I like to walk around. I like interaction. I like to ask questions and get feedback. So Zoom is super tough for me, but I'm going to try to make this work. And I just can't imagine how, knowing the eating style that you are used to now with the pandemic and having perhaps someone else do your shopping, or, it's almost like you have to get a PhD scientist to get in there and look at those nutrition labels to find the right products for you. So I really got to hand it to you for the last 3 or so months. I'm sure that you have had a lot of challenges. But next slide. So some of the objectives today, to discuss ways to develop an FCS-friendly food plan that works for you. You guys are the experts, really. Usually we're singing to the choir. Probably who's ever on this call should be giving this talk rather than me. But if you can find one new thing that comes out of it that you can go and either buy or try a new recipe, I hope to give that to you. To review options for substituting ingredients to make cooking tasty and easy, and also to provide you with some recipes that you will get by email after this. And they're just some of my favorite summertime recipes, because summer's a great time for people with FCS because fruits and vegetables are abundant. People are growing things in their garden, and you're getting maybe some free zucchini, or, so you got to figure out what to do with all that. And it's naturally fat-free and good. So next slide. Some disclaimers that, whenever we do nutrition advice presented to general audience, remember that your own healthcare professional knows what's best for you. It's hard for us to speak, especially when it comes to, something as rare. Each of you has your individual tolerance for certain things. So always check everything through your own healthcare provider. And I do use some brand names just for convenience, but it doesn't imply any endorsement. And there is a great kind of a best practices paper that was published in the Journal of Clinical Lipidology in 2018, where they put some guidelines together, not just the very low fat part of it, but some other guidelines as well. And that's what this talk is based on. Next. So here it is. This is a big slide, and you will be getting all of these slides, or everything's being recorded. So I have a lot of information here, but the first one, eat 10 to 15%. For most people, that's up to about 20 grams of fat per the day. Some of you say I can't have more than 4 grams for a meal. So everybody has their own way of doing that. The next one is include a source of essential fatty acids. And we really, I don't think, see essential fatty acid deficiencies, but there are some essential fatty acids that your body does not make that you need to provide. And one of the important ones is alpha-linolenic acid. And we find that very concentrated in chia seeds and milled flax. So a recommendation could be to include a teaspoon of chia or milled flax once a day. That teaspoon will have about 1 to 1.4 grams of fat for the teaspoon. So use that as part of your fat allowance. And I did make this weekend a really great peach smoothie that I included the recipe for. And I used a teaspoon of the chia seeds in it. And it really, gave the smoothie more body. And if I wanted to freeze the leftovers, because it was a lot for one person, but it would be a meal for someone. But the chia seeds really helped it because they almost act like tapioca, making it thicker. So, and you can find them anywhere, and they have the nutritional analysis right on the label. I have these organic black chia seeds. So you just check the nutritional analysis. Next, select lean proteins, which you all are very familiar with. One thing I think people are not maybe eating enough of that's such a great source of protein and a fiber is beans. So think about, what you can do more with beans, adding to salads, having as side dishes, making pasta fagioli, where you thin out the pasta that you're eating with some beans. And also the low-fat peanut butter. I think a lot of people do use that. Next, enjoy generous portions of vegetables. It's really kind of about how can I eat more vegetables today? How can I fill half my plate with vegetables? How can I have a big salad and vegetables for dinner? So again, summertime is great for that. And moderate amounts of fruit. And when doing so, whole fruits or fruits without added sugars. Next, choose primarily whole grains. So, even though, white pretzels and white bread may be almost fat-free, it's really looking at some of the whole grains that are available, especially some of the newer ones, maybe like farro that you haven't tried, or quinoa that are, available even pre-cooked, easy to use, throw into soups, use as a saute or something. And avoid refined grains like white bread, white crackers, and white rice. Use fat-free dairy and I feel bad because they're getting to be less like fat-free sour cream out there, but I think we'll always have the fat-free yogurt, and using, you know, in my refrigerator, the 0% Faye yogurt I use with everything. It's a great thing. And also fat-free cottage cheese. I know a lot of people use that as a good protein source for their meals. Minimize added sugars. So this is sodas and sweets and foods processed with added sugars. Eliminate alcohol, balance food intake throughout the day, especially that fat part of it too, and use activity to help you maintain a healthy weight. I'm not much for diets to lose weight. I really think we need to look at habits, and those are the things that stick with us, is really you know, thinking about when we eat, why we eat. And I think for most people that I've spoken to with FCS, it's really challenging to maintain a healthy weight. They're on the thinner side. Lastly, and don't forget, staying hydrated is so important. So putting together some spa water for the day and keep it out on your counter is a great idea. Okay, next. I wanted to go through the food label because it is new for January 2020. All companies need to comply with the new guidelines. So first, which is next, we have an arrow. So next. Good. We got more realistic serving sizes. So let's say this might have been ice cream. By looking, I'm not exactly sure what it is, but I'm going to guess it's ice cream, although it does have fiber in it, so maybe it's not. But they're more realistic serving sizes. So maybe it used to be a half a cup, but most people look at a half a cup and they don't really get they're really having a little bit more than half a cup, or sometimes a whole container. But the serving size is now 2/3 of a cup. So more realistic serving sizes. So be sure to check that out first. Next. We have 8 grams of total fat that you're used to looking at. Of course, you would never pick this product, but you know, we just zoom in on the total fat. It really doesn't seem to matter what kind of fat it's coming from, good fat, bad fat, saturated, blah, blah, blah. It's just all needs to be, you know, lipoprotein lipase needs to be used for all of it. So, and then next is the best thing I think that's new on the label is the fact that they're putting added sugars on the label. So now you can figure out if something, you know, if you're comparing products to get the one with the least, or the added sugars do not include the kind of sugar that you get from milk, which is lactose, and then the kind of sugar that you get from fruit. So those are not considered added sugars. But before, it was very tricky how they did the ingredient list, and something could have tons of added sugars, and now you can really get down to the bottom of it. So those are the things I look at on a label to really zero in. Okay, next slide. We have some smart substitutions. So I think you all know what's going on here. If you like these things, try these instead. And you see, I'm just going to highlight a couple things on here. One of them was the neat egg is made with garbanzo beans. So it's an alternative, let's say, to egg beaters, or you can use it in a recipe. So that's something, you know, somebody might like to try. Canadian bacon and bacon bits, always look at the ingredients, but the nutrition label, so you can see how many grams of fat. But sometimes it's a tablespoon, could be a serving size, and it's 1.5 grams of fat, but you're choosing to put bacon bits into a vegetarian pea soup, let's say, just to give it more flavor that you might enjoy, and you're flavoring the whole thing with a tablespoon. So you're really using these not as protein sources, but as your flavor enhancers. And then we have lots of new veggie burgers on the market, but just be careful for the newer two that are out. currently the Beyond Burger, those have a lot of fat and are not going to work. And portobello mushrooms always work on a grill, fantastic. Throw on some Worcestershire sauce and you've got it made. Seafood, great. Skinless chicken and turkey breast. I don't know if anybody's tried this. One of my favorite products. I have it here. It's this Jenny O oven ready turkey breast that you can put in a crock pot. It's, you know, no trouble. You just throw it in, and it only has 1 gram of fat in 4 cooked ounces. So, you know, it's something that you can just go to. And then, of course, don't forget your beans. Okay, next. Dairy, I think everything's pretty much, you know, the same except for a little less with the fat-free cheese available, the fat-free sour cream, of course, when it comes to the ice creams and things, you really want to look for things that don't have as much of the added sugars. I was able to find a sugar-free, fat-free fudge pop, or maybe, yeah, it had like maybe 1 gram of fat or less. And of course, go to your, you know, desserts like your fruits and your frozen grapes, and then making some homemade smoothies and make your own ice cream bars from those. Next. When it comes to oil and butter, I think first, you know, we look at what we can put on our bread, and we do have fruit spreads and the powdered low-fat peanut butter. When it comes to the butter spray, remember that, you know, one spray may be almost no fat, but if you've used butter spray, sometimes you can really power it up and end up with a lot more. So when I checked with the company, they said that 10 sprays was equal to 1 gram of fat. The same thing goes for the PAM spray and stuff. So if you're using PAM on a pan and the whole thing that you're making has no fat, then a little bit maybe that's on the pan is something that you can handle. For oil to saute, my favorite thing is fat-free broth, and I do use those better than bouillon because you can put it in the refrigerator. They have vegetarian, they have chicken, they have beef, and they don't have any fat. You could just use like a little teaspoon or much less with a tiny bit of water, and don't have to use like a whole bouillon cube or open up a can of broth or a box of broth and then waste the rest of it. For oil and butter for baking, my favorite thing is just to use the fat-free yogurt. I find that's best, but you know, for you all, the unsweetened applesauce, a date puree, a prune puree always is good as well. Always try the recipes ahead of time because you don't want to have something that doesn't turn out and you're having company over. And some things are a lot more forgiving. I mean, when it comes to a loaf cake or muffins, those are forgiving. A layer cake, touchy. You know, that's, you have to watch out for that. Mayonnaise is the next thing, and I am happy to say that it does seem like a lot of the markets still carry the fat-free mayonnaise by Kraft, but you could also use fat-free yogurt or mustard or some fat-free ranch dressing to make something creamy like a salad. And then salad dressings, you've got lots of fat-free dressing choices, and then you've got your vinegars, your flavored rice vinegars, and of course, fresh lemon and lime is always the best. Next. And lastly, we have sweets. And you know, it's funny, this chocolate, you know, you could use the Hershey's chocolate syrup, but that does have sugar in it. You know, people have a taste for chocolate that just, you got to have a little bit of chocolate. And I know I sound like a commercial and I don't work for any of these companies, but this Wax Orchard's classic fat-free fudge topping has been around for maybe 20 or 30 years, and it is fruit sweetened. So it still is a source of sugar. You're not going to be eating the whole container of it, but you know, for a little teaspoon, it's great. And it has pineapple concentrate, pear concentrate, and then cocoa powder and vanilla. So that's the only ingredients in the wax orchards. And they do sell it at Whole Foods, and you can get it online as well. When it comes to chips, I think, and crackers and things, I think, you know, the best out there really is that Wassa crisp bread, because it's crunchy, it's whole grain. So, you know, there's lots of fat-free crackers or fat-free pretzels, but you really do want to look at 100% whole wheat, or you want to go toward the whole grain products that don't contain fat. You can make your own corn chips with corn tortillas don't contain any fat. And then when it comes to nuts, of course, tons of fat, but you've got your air pop popcorn. So everybody should have an air popper at home, and you get that popcorn, and you've always got a snack. And it's something that great for the pandemic, because it doesn't even go bad. It'll be here for the next couple years when you have, you know, a container of your popcorn kernels. And then some people like to try the baked garbanzo beans, where you put it on a pan in a 375-degree oven and just maybe sprinkle it with some seasoning or hot seasoning if you like, and bake them till they're a little bit crispier. And for French fries, I know a lot of people have air fryers, and the last Consumer Reports, they did say which was the best, and it really wasn't very expensive. I forget which one, but you know, an air fryer is a great idea. Also, your own oven with nonstick aluminum foil and baked potato wedges can, you know, anything tastes good when it has that little crispiness on it. Next slide. Yeah, so it's really, you know, so we've got the low fat part down, and I know it's tough, and I think most of you who are eating very carefully kind of get used to it, and it's just the way you eat, and it is a taste perhaps that you prefer. I personally prefer a lower fat taste, and realized it because I make this tuna noodle casserole with the Healthy Request cream of mushroom soup, and it just wasn't available. You know how soups were all out in every grocery store, and I ended up having to get the regular. And when I made my tuna noodle casserole, it tasted terrible. It was like, it just was coating my mouth, and it had a horrible taste because it had so much more fat. My husband, of course, liked it more, but for me, it was just, you get used to a certain taste. Anyway, we'll go with the whole grain now and take a look, you know, if there's a way that you can improve your eating at all. Maybe it's looking for whole grain products. Substitute whole wheat flour for half of the white flour when you're doing a recipe, and try the white whole wheat flour. I have some here, and again, flour was out everywhere too. Luckily I already had this, but it was white whole wheat flour, and it's white so nobody knows that your product looks like it's brownish, and it also is more mild tasting, so it doesn't have the strength, that stronger taste of a whole wheat flour, and you might be able to sub it out and nobody will know. Choose brown rice, barley, whole wheat for your pasta, for side dishes and your salads. Experiment with the trendy, we already talked about that. Select whole oats and other whole grain breakfast cereals, and then what to snack on. Next. Keeping my eye on the clock because I want to get us going here. Let's see, recipe makeover. So here was a recipe that one of our exercise physiologists brought into cardiac rehab one day, and it was pretty good, but you could tell it had a lot of something in it. And when I asked her for the recipe, I could see it had everything fat, it had everything sugar, and everything white. So then I redid the recipe. So take a look. This is the redone recipe. So next should come up. There we go. There's your FCS friendly bread pudding. So it was easy just to use the whole wheat bread. I used the crushed pineapple in its own juice. I subbed out all the sugar and just used either one of the Splenda type products. If you were making it for company and you wanted to throw in 1 tablespoon of brown sugar, you could. But it tasted really good without anything else. Of course, the milk. Then I used a fat-free, egg substitute, the egg beaters. I just took out the butter completely because a lot of the recipes if you just take it out all the way, it's not going to suffer. And then the vanilla extract, and then you can see the difference. We went from 14 grams of fat for a serving to 0.4 grams of fat. So that was a good way to do it. And you can find this on fcsfocus.com. I used a similar recipe for the holiday recipes when we did a webinar, and I used bananas instead of the pineapple. So you could sort of use some different fruits in there too, because very forgiving of bread pudding. Okay, next. So we've got all of our summer fruits. This is one of my favorite fruit stands, and they just, the pictures that you could take there are so pretty. But you've got lots of your homegrown things. For vegetables, you've got all your fruits. You've got the beginnings of tons of garden salads with beans and citrus dressings. You've got your pasta, your whole grain pasta, or your potato salad made with, again, any way that you can get some extra vegetables in there, some red peppers, some, cucumbers, and then even if you could throw some beans in or make a 3-bean salad that doesn't contain oil, and then using your fat-free mayonnaise or non-fat yogurt. And I have a couple recipes for those things in the recipe grouping. Coleslaw, easy to make. For the pandemic, it seems those bags of slaw or a head of cabbage is something that will last forever in your refrigerator and not go bad. So those are the kind of things we're looking for that have some staying power, and you can always put together a fun slaw. And then don't forget the hydration and doing some spa water with cucumbers and berries, cantaloupe, basil, mint, rosemary, or sage, and having it where you can see it, a see-through container, always a good idea. So it entices you because it looks good and you feel like you're at a spa. Okay, next. Fire up the grill. So we're outside, days are nice. Now we've got plenty of time to grill. You've got lots of fresh fish and shrimp. Shrimp in 3 ounces cooked has like less than a half a gram of fat or something. So that's something you can overeat on if you can afford it, because unfortunately it's a little expensive. Chicken breast with lots of fat-free marinades. Ground turkey breast burgers, I usually kind of cut the burger, maybe put in a handful of oats, egg white, and then some ground up mushrooms. I just put the mushrooms in a little food processor and just process it and put those in there along with some ketchup or other seasonings to give it a little bit of the turkey breast burger, because it has no fat, could be a little tough. And when you plump it up a little, it's nicer. The portobellos, just, you can marinate those in the fat-free marinades or Worcestershire sauce, and then just put those on the grill. Barbecued corn. One of my favorite things is a grilled red onion. Do extra of a grilled red onion. Just put thick slices on your grill and brown char it and use it for the meal, but then leftover cold, you can't even imagine how good it is, because somehow, that onion caramelizes and it just becomes sort of sweet, and it's really nice. And then grilling fruit like peaches or pineapples, fun to try. Next. So some of the summer favorites we've talked about: the confetti coleslaw, barbecued veggies. You can even do inside with a low sugar barbecue sauce and just brush the veggies and do it inside and get it really brown, but have a nice barbecue flavor because of the sauce. And I'm giving you my recipe for my Maryland crab soup. I'm from Maryland, and crab has, again, just like shrimp, almost no fat. So using, like an 8-ounce container of crab meat legs, which is the least expensive version, and then just putting lots of veggies in there with fat-free beef broth. And the key is Old Bay seasoning. And you can usually find that in the section where you buy fish. Next. And speaking of Maryland, here I am at a crab feast where we put the, newspaper down on the picnic table and talk about some slow eating. People will eat these things for 5 hours because they take so long to eat, but they really are delicious. And it's making me a little homesick for home because now I'm in California. But anyway, this is a picture of one of the crab cakes. That other one was a picture of the crab cake. And I'm telling you, with no fat, that crab cake tastes way better than it would if you got it in a restaurant in Maryland. So, try the crab cake recipe. And lastly, why fry? Well, we have air fryers. We don't need to fry. Fry, of course, look at a tablespoon of oil has like 14 grams of fat, so that would never work. But one of the things I do at home is I use, to get some extra flavor if you think you need it, I used a fat-free ranch dressing to dip in first. Then I put it into whole wheat panko breadcrumbs that I've seasoned. I have it here with Tony Chatri's, Creole seasoning, but you can do any, Italian seasoning or anything you like. And that right there is the result. And it looks good and it tastes good too. So there's, I think anybody can cook with fat, right? And make everything taste great, but it isn't very challenging. So making things taste good, and first of all, lots of stuff already tastes good, just the natural way it is, like fruits and vegetables and things. And you really taste the flavor of something rather than a taste of butter or a taste of oil. You are truly tasting the real food, and that's a good thing. Next. And there you go. And that's about it. So don't forget to write your questions in chat. If you have any questions, this is the time to get them out there. And I think we're going on to Melissa next, right? Or are we?
Yes.
Yeah. Okay. Hi, Melissa.
Hi. Thank you so much, Mary. It's so funny you mentioned the tuna noodle casserole, because in this whole COVID thing, that was one of the things I've made for the very first times ever. I've never made it, and I wasn't going to the store, but I had all the ingredients, and because I had stocked up on cans of tuna.
Right.
And I made it, and I thought this is going to go one of two ways. My kids are going to love it, or this is going to be one of those conversations where I tell them they don't have to like it, but they have to eat it.
Right.
And they loved it. They've asked me to make it multiple times since I made it at the beginning of all this.
It has been one of my favorites, even growing up. Of course, my mom made it on Fridays and, made it really fatty. But the way I make it here, and I can get it done in probably less than 8 minutes. And again, most of it is coming from a can because you're starting, and then you've got canned mushrooms and you've got your tuna and things that last a long time.
Right.
And then I usually either throw in frozen peas to give it a little bit more color, along with pimento is a must. So I always have that stocked in my pantry. And then also water chestnuts to give it a little crunch rather than, because some people would put all those greasy onion ring things all over it. So we don't do that. And I don't even bake it in the oven. I just pop it in the microwave, and I am from start to finish at the table in 10 minutes.
Yeah, they really liked it. They made me laugh because they were so excited by it. And I threw in an extra can of tuna because I figured that's extra protein.
Yes,
and,
I always do that too.
And I put the breadcrumbs on top, and it's so funny you say you don't need, I put the breadcrumbs on top and I baked it, but I didn't put any butter on top of it. It's still
and your whole family could eat it, and it's good for Juliana.
We all ate it. I mean, it was my son who requested it again, and he doesn't have FCS, so
there you
go.
go.
Funny that you said that, because I'm like, we're like new tuna noodle casserole lovers over here. It's funny.
Yeah. And I always
Um,
think ahead because maybe I'll make the whole wheat pasta, or sometimes the black bean pasta, or one of the other, kind of more fibrous pastas. And then I'll just have a baggie of it left over so that I can throw the cold, pasta right into it. And then it makes it,
oh yeah.
The less than 10-minute version.
Well, thank you very much. Those are all such great ideas. And like Mary said, I hope, someone can take away even just one new idea. I was writing notes here myself, because even 7 years of cooking low fat, there's things I forget or new things that I always learn, and it helps keep things fresh for us so we're not getting bored with what we're eating. So we did have some questions that came up during the presentation. I know that they were answered, but in case you didn't see them, I'm trying to see if I can scroll up, sorry. I don't know that I can scroll up to what the question was. I don't know if Sarah or Chad. I think the question was about to Arrowhead.
Yes, if there's any side effects from the patient trials that are going on with ApoC3 and the current phase and anticipated roadmap for approval.
Yeah, sure. I can address that. The main side effect that we've seen are transient redness or some bruising at the injection site, and it typically resolves within a day or so, and most cases have been mild, reported as mild. And we've seen the pictures of these. It usually looks like an area about the size of a nickel, maybe. That's a little bit of redness and a bruise that tends to go away within a day or two. We see the occasional elevation in liver enzymes. We also see that in the placebo group as well. And so that's something that we're watching carefully. Those also tend to be in a category I would call mild and self-limited. They're typically back to normal by the end of study. Now, the patient part of this study is still blinded. We've completed the healthy volunteer part of the study, but the patient part of the study is still blinded. So we don't know who's on drug and who's not in the patient part of the study. We should know that before the end of the year. And then the other question was on stage of development, I think. Yeah, so the current study is a phase, what we call phase 1/2A. So it's basically a safety study in healthy volunteers, but also an attempt to show some early signs that the drug is working, that it's doing what we think it should be doing by modulating ApoC3 and triglyceride levels. The plan would be that the next stage would be a phase 3 study that could be used as part of a registration package with regulators, part of a package we could use for approval. But those discussions are still ongoing with regulators, and I think we'll probably know more over the next year or so. So we don't have definitive plans now because a lot of that is up to FDA. Hopefully that gives some color into those questions.
Great, thank you. We had a question if Dr. Ahmed can elaborate on what GI disturbances can be attributed to.
Well, so I believe Lucy asked that question. Thank you for asking that. The GI disturbances in FCS are mostly related to pancreatitis and pancreas issues. Beyond that, I'm not aware of any symptoms per se that people may have. I mean, of course, you can have nausea and vomiting, abdominal pain with pancreatitis, and even without pancreatitis, it seems like FCS patients can have that. Maybe Dr. Singh could elaborate if he can think of other GI symptoms and what they may be attributed to, other than just the high triglycerides and the pancreas.
Yeah, no, that's a really good question. I think you're hitting the nail on the head. Most of the GI symptoms are attributed to recurrent acute and ultimately uh, the development of chronic pancreatitis, as well as diabetes. So, I think we need to keep in mind that, if you do develop diabetes, then that has a lot of impacts on gut motility, which can certainly lead to symptoms like nausea and vomiting, especially if you're having a really difficult time controlling your blood sugars. Um, in addition, diabetes can have a contribution towards pain and other sort of neuropathies that don't just simply have to affect the extremities. They can also affect the abdomen. Let's also remember, when you get chronic pancreatitis, then all the functions of the pancreas are impaired, right? So apart from the diabetes, some patients can develop exocrine insufficiency, so they're not making enough digestive enzymes, and that can result in malabsorption. So they can actually develop those oily stools that are often also referred to as steatorrhea. In addition, the pancreas makes base, right? So if your stomach makes acid, the pancreas makes base, and the combination of what's coming through the stomach and into the intestine, along with the base that the pancreas is producing, leads to sort of more of a neutral pH environment in the intestine. So anything that changes that intestinal pH can lead to really what we call bacterial overgrowth. I know the gut microbiome is a hot topic. I think every day there's an article in the New York Times or somewhere in the popular press talking about our gut bugs and gut microbiome. And so, that gut microbiome can be impacted by those changes in the pH in the intestine. And those can result in a whole host of symptoms, right? Everything from the gas, the bloating, you got to sort of undo a couple of buckles on your belt, when you're getting bloated. Those symptoms can be very much associated with that as well. So, I think that a lot of these symptoms ultimately, though, still at the end of the day are consequences of the long-term recurrent acute and possible development of chronic pancreatitis.
Vikesh,
Yes.
does the chylomicronemia itself, with exacerbation of chylomicronemia, does it affect blood flow through the capillaries throughout the entire abdomen, the mesenteric arterial system, and could that cause pain?
Yeah, that's a good question.
Sludging.
It's very difficult to study. We do know that, the one thing about the gut that's interesting is there's a lot of what we would call collateral vascularization, right? So almost every part of the gut, there's some redundancy. So, it's not, most areas are not just fed by one vessel, but kind of a network of vessels. So as a result, it takes a lot to sort of, cut down and impair that blood flow to the gut. I think those patients who develop atherosclerosis of the big vessels, certainly of, the aorta and its branches, could be at risk of that. I have seen some individuals like that. So maybe not so much in the FCS population specifically, but patients with other hypertriglyceridemic disorders that can happen. But it is unusual to expect that the chylomicronemia itself is actually contributing to this sort of clogging event and possible gut ischemia. I don't think we see it as much as it may be, suspected to be. But
Great, thank you very much. We have another question from Dr. Rosenblit for Mary. I know this is a question that comes up a lot. Could you discuss MCT oil? Maybe how it can be used, how that, if and how that counts towards daily fat intake, just general. You're muted, Mary.
Okay, I'm back. Yes, thanks, Dr. Rosenblit. And I usually have a couple slides on MCT oil because I love it and, have done many recipes with it. And for some reason, I looked at the time and I thought, well, maybe I won't have time. So I didn't. And then, it's a great source of calories. You do not need to include it as part of your fat allowance. So if you see a tablespoon has 14 grams of fat, that is mostly, or it should be, well, let's start over. Number one, when you buy MCT oil, you really should be getting it from a reputable source, because something like coconut oil may have these medium chain triglycerides, but not all medium chain triglycerides. They may have additional long chain fats, and it's the long chain fats that you are not digesting because of the lack of lipid or activity of the lipoprotein lipase enzyme. So you want to find something, and usually it is through a pharmaceutical agency that you would get it, because when you just go online and put MCT oil in, you don't know what you're getting, because the FDA does not regulate those products, and those products could be sold for, you know, someone for fitness and for the different, like, we don't want belly fat or something like that. So usually we would purchase through, let's say, Nestle, but it's very expensive. A pint is like about $60, but you really don't use that much of it. So the tips for using MCT oil, once you get the correct MCT oil, is that you just start with a teaspoon a day, because of your you know, tendency to have abdominal pain. We don't want you to have abdominal pain, and people with FCS tend to be a little bit more sensitive. So if you didn't have FCS, I'd say a tablespoon a day. If you did have FCS, I say start really low, just use it as a salad dressing, use it for extra calories in a smoothie. If you are sauteing it, it has a smoke point that burns in a second. So if anybody watched the webinar, I made latkes because it was holiday recipes and for Hanukkah, and we use the pan but on a very low heat. So you can use it to saute, but it must be less than 325 or 350. It's just a really low heat, and keep your eye on it so it doesn't smoke. But otherwise, for salad dressings, it's great, and it can be used in recipes as well. So good source of calories, because if you're eating 10% of your calories from fat, and then let's say you're eating 15 or so percent of your calories from protein, because at some point, if you eat too much protein, even if it's lean protein, it's going to add up to some fat. So there's a limit to how much lean protein you can eat. So the rest of your calories are as carbohydrate, and that carbohydrate load is something that you want to blunt a little bit by monitoring your portions of the carbohydrate you're eating, and put some of this MCT oil for the extra calories. So it's a great product, and sometimes physicians, depending on the lipid clinic, I don't know how you do it, Dr. Ahmad, let's say, or if you write prescriptions for it and then insurance may cover it. So those are some options.
That's a good transition, Mary, actually, to our next question, which asks, any limits on carbohydrates, recommended number of grams per day, and can you explain the difference between sugar and sugar alcohols?
Okay, good questions. You guys are really, this is Nutrition 601 instead of Nutrition 101 here. I forgot, this is the group that knows everything about food. Let's see, I'll do the sugar alcohol question first. And sugar alcohols are more slowly absorbed, and they usually have the word OL on the end of it, like sorbitol. Okay, so sorbitol is maybe put into, let's say, an ice cream, and it could be called a sugar-free, or it doesn't have added sugars, but the sugar is there, a sweetener is there as sugar alcohols. Sugar alcohols still have calories, but they're absorbed more slowly. I think sugar alcohols can be a problem because they are absorbed so slowly that the gut bacteria love them and start to produce carbon dioxide, which could cause you to not be comfortable in your stomach or have some abdominal pain, even to diarrhea. So that's why, I usually look at sugar alcohols and somehow I would prefer, if I'm using a sugar-free product, that it contains stevia or a sugar substitute rather than the sugar alcohols. But they are still there as grams of carbohydrate. For the next question about the grams of carbohydrate, that's really something that somebody would perhaps work on with a dietitian to personalize an eating style for them, because each of you has a certain caloric need. And if we were calculating 10% of your calories from fat and then protein, and depending on how sensitive you are, maybe a dietitian or a physician or a physician's assistant would look at at triglyceride levels over time and see if you're one of those people that's pretty sensitive to it. I think, it's rather than, because you guys are already thinking about fat, and then you got to think about it's so much to think about. We never want you to lose sight of the fact that fat is the most important thing. And then the icing on the cake is, let's get rid of those added sugars, let's move to some whole grains, and then see how you're doing as far as your lipid levels go and your admissions to the ER. One of the things I use at home to keep myself on the straight and narrow sometimes is just a scoop, and this is a half cup. And I got it online on Amazon for like $5 or something. So it kind of reminds me that I probably don't need more than this much whole wheat pasta and lots of vegetables. And then, so I think of it as a plate. And that's an easier way to think of it, where half your plate with vegetables, a quarter of your plate with lean protein, and then a quarter of your plate with some kind of a whole grain starch. And that's usually a pretty good way to think about it. I hope that answers the question.
Thank you, Mary. I know that that's a question that comes up often, and if there's other questions that we have or clarification that any of you would like, please feel free to continue those questions coming, post the meeting. We can continue. Like I said, the conversation is ongoing, so feel free to send those to us. Slides and playback will be available post-meeting. They'll be sent out along with the recipe book, so you'll all get that, and then we'll make that playback available to anyone who may have missed it as well. And we would love to get a photo of everyone that is here on the call so that we can share that and hopefully get people excited for our next webinar. So if you would like to not be part of the call, feel free to turn off your camera and opt out of that. But if you will, we would greatly appreciate your smiling face on our photo. So, and Sarah's going to go ahead and take that.
Yeah. Thank you so much. The way we'll do it, because of some of the limitations, is we're going to close out the slide deck. So don't worry when you see your view change, and hopefully the rest of the grid will show all of us in one photo. And there we go.
Yay.
Smile. And everybody can wave at this one. We'll do a hi with hands.
Perfect.
Very, very good, Ben.
Thank you so much, everyone, for joining us, and we hope that this was informative and that you got some questions answered. And thank you so much to our Medical Advisory Board for being here, and our board members. It means so much to us to have you all engage in conversation too. It's exciting for us. So thank you.
Thanks, Melissa.
Thanks, everyone.
Thank you.
Thank you.
Thanks
Bye.
for inviting me. Bye.
Thank you. Take care.
Bye.
Everybody stay safe.
You too.
Thanks.
Thank you.